Actually, our next speaker may be able to address some of those issues that were just brought up in the last question as well. It's my privilege to introduce Dr. Marv Seppala. Dr. Seppala is currently the Chief Medical Officer at Hazelden and serves as Adjunct Assistant Professor at Hazelden Graduate School of Addiction Studies. That's in Minnesota. Dr. Seppala and I are both from Minnesota. He's kind of started out on the wrong limb heading to a competing small college called St. Olaf, but lasted there for a couple of years until they moved him on to Iowa. And so Marv graduated then from Drake University in Iowa, came up to Mayo Clinic for medical school in 1980 and was there from 80 to 84, and then ascended and headed up to Minneapolis, did residency in St. Paul and in Minneapolis in psychiatry, and then did a fellowship in addiction medicine in the late 80s. And then in the intervening 20 years, he spent most of his time in Oregon and was consulting psychiatrists to addiction centers in Oregon and around the Beaverton and in Portland area. Was also back in the Twin Cities, was associated intermittently with Hazelden during those years, and then decided to come back and last year, almost just a little 13 months ago, was named Chief Medical Officer at Hazelden. He's been an author, has co-authored several books, including When Painkillers Become Dangerous, Pain-Free Living for Drug People. He's also been consulted quite a bit, has appeared as a national expert on addiction treatment. He's been a guest on The Early Show. He's been on NPR. He's been quoted in the New York Times, the Washington Post, USA Today, Newsweek, and the Wall Street Journal. He's spoken literally around the country, in Europe, in New Zealand, and in Australia. It's really an honor for me to introduce Dr. Seppala.
Well, it's a treat to be here, and especially spend some time with Frank. We were medical school classmates and have really reinitiated our relationship in the last couple of months. I was able to come out here and do some skiing, and you folks live in a wonderful part of the world. I just moved from Oregon back to Minnesota last year, and this is the Wallowa Mountains out in Oregon. Unimpressive to a group living here in Ogden, but remarkably impressive to Minnesotans, you know. My son and I went backpacking up there a few years ago. And I'm impressed by the number of folks that are still here on a Friday afternoon to listen to someone talk about addiction. Unusual. A friend of mine, LeClaire Bissell, was one of the early experts in the addiction field, and she would go around the country, you know, speaking at grand rounds in different hospitals, and she would ask them to put on the, you know, calendar that DeBakey was going to come and speak on heart surgery and heart transplant surgery so that the whole room would be filled, and at the last minute he couldn't show. So she would come out and speak on addiction and actually have an audience. So appreciate the people still hanging around. I want to talk a little bit in the vein that other people have already about what's new in my specialty. By doing so, looking at some of the newer research, our understanding of the neurobiology of addiction and how that not only drives some of the decisions that we make in this field, but it helps to understand some of the treatments that already do exist, and I'll end with a lot of that. In general, just looking at addiction itself, it's characterized by loss of control of substance use. So you see a gradual progression into increasing use, and it becomes uncontrolled in a manner that the individual can no longer just, you know, predict what's going to happen once they start. Continued use despite adverse consequences. You know, the problems start mounting up. The individual doesn't recognize them or may recognize them, but still decides to continue use. Easy example, you know, an 18-year-old has a minor fender bender and doesn't have a history of addiction or a predisposition to it. The fender bender occurred while using some alcohol, decides, you know, I shouldn't do that anymore, and doesn't. The alcoholic, or those predisposed to alcoholism in the early stages of it, might have the fender bender, and then a couple of nights have the same thoughts, I shouldn't do that anymore, but a few nights later they're doing it again without recognition of the initial difficulty in that decision. tolerance and withdrawal, the biological markers, as well as chronicity and relapse. The more we know about this illness, the more we know that it's a long-lasting, lifelong illness. We don't talk to people about getting sober now for a few years and then trying it again. We talk about lifelong aspects of it. And this is in some ways the holy grail for the researchers. We don't know why exactly at this point in time it's a long-lasting, lifelong chronic disease and that relapse is possible. But it is a brain disease, not necessarily noted when I was in my training, when we said it was secondary to some other psychiatric illness, often depression or anxiety, and that's still often a discussion that, that this person is just using the alcohol to treat an anxiety disorder. It's not a moral or ethical problem. One of my professors in my residency training did a lot of animal work, and should have. He wasn't that good with humans, but he was great with rats. And he said that he could order a strain of rats to study, and the strain would not touch alcohol. Couldn't make them drink. He could inject them with alcohol. He could put them in situations where that was an automatic sort of thing in the research. However, they wouldn't drink given the opportunity, even when stressed, stressed in somewhat nasty ways. He could order a strain of rats that would drink alcohol. They'd drink water. They really didn't care. Didn't have a preference for the alcohol. He could also order a strain of rats that drank alcohol till they died. They wouldn't stop drinking alcohol and would discontinue other normal rat behavior. They'd quit nesting, quit mating, have trouble with basic physical functions, and slowly drink themselves to death. And so he summarized that by stating he'd never met a rat with moral or ethical problems. And I thought it was a good description, since again, this is one of the ways we look at the disease of addiction. No longer considered a personality disorder. You'll see in the literature occasionally that addictive personality is mentioned. When people are in the midst of addiction, their personalities start to look alike prior to the addiction, and there are studies that show this with MMPI data and other psychological testing data, that prior to the onset of addiction, broad array of personalities, they start to kind of narrow during the middle of the addiction because they're all doing about the same thing. And then they stop using, get into recovery, and it broadens right back out. Nor is it a choice, which we're going to talk a little bit about. Initiation of substance use is absolutely a choice. The ongoing use in the midst of addiction does not appear to be a conscious decision anymore. So I'm going to describe some of that neurobiology. The newest theory is that this is a disease of learning and memory, that these substances of abuse all cause supraphysiologic release of dopamine in the limbic system of the brain. And that supraphysiologic release results in recognition of the reinforcer, the use of the substance, remarkably more powerfully than any other natural reinforcer. Whereas sexual activity, survival of the species requires it. It should be at the top of the list, for survival itself, and our innate drives gets reprioritized down below the continued use of the substance based on the fact that more dopamine is released from these addictive substances than from sexual activity, than from great food, great chocolate, normal human experiences and reinforcing activities don't stand a chance against this sort of the salience of this stimulus in the brain. And that's how we're coming to understand addiction. It gets laid down in memory at a subconscious level, the limbic system not in the cortex, although there's connections, dopaminergic connections to the frontal cortex, which we'll talk about. The main aspect of it is occurring at a subconscious level and reprioritizing drive states in such a way that after a certain point, the individual is no longer truly making decisions about their ongoing use. They're just naturally going to do it again. We know that, again, kind of a review of what I just said, basically, that all these rewarding activities are the result of a release of dopamine, or result in dopamine release in the brain. Dopamine can't inform anything more than the salience or the importance of the event that occurred. And in general, we see that as the importance of the reinforcer or the reward itself. And all drugs of abuse cause this supraphysiologic increase. So you look at it in kind of this manner. When I see a methamphetamine addicted mother who's neglected her children while on a methamphetamine run, and she's been taken in by, the social services department. She hasn't been with her children for 3 days. It isn't that she doesn't love her children as much as any one of us loves our own children. It's that she's been in a position where that decision is being overridden by something else. Much like these salmon that we see out in Oregon, and they're running upstream to go and take care of the next generation. They don't have a choice in that. And I sat along a waterfall similar to this one and watched salmon pound themselves against the rocks trying to get upstream. And those that are unable to do so don't turn around and go back to the Pacific and wait it out till next year. They're either going to get up there or die trying. And in the midst of addiction, it's somewhat similar, that people are just going to keep going after the same stimulus over and over in an unnatural way compared to the rest of us that don't have addiction and are examining our life decisions. The prefrontal cortex also plays a role. Prefrontal cortex is our executive decision-making, judgment, that sort of thing occurring. And the orbital frontal cortex, who's familiar with Phineas Gage? Right, Ron? So Phineas Gage, a famous guy, he was out laying railroad spikes, started tamping down, some dynamite, and his rod came back up through his head and took out his prefrontal cortex. Phineas Gage lived through that, at least for another 7 or 8 years. However, his personality dramatically changed. He suddenly he was a remarkably sort of religious, straight-laced guy. Suddenly he was swearing, lying, cheating, going places he'd never gone before. And that was the only real significant change related to this dramatic brain injury that you'd think would have killed him. Took out his prefrontal cortex. There's been remarkable studies of his skull to reconstruct exactly what part of the brain was taken out. And when we look at the behaviors associated with addiction in the midst of the disease, it's much like Phineas, that people start doing things they'd never done before. They start lying, they start cheating. The frontal cortex itself is no longer functioning in the same manner, both for decision making as well as for personality change associated with this kind of ethical activity. And perhaps that's where some of our biases come in regard to addiction. Now, this comes from NIDA, National Institute of Drug Abuse. So they're kind of trying to make a comparison, looking at some scanning studies, and you can see we've got the brain over here. Here's a prefrontal cortex well lit up in a healthy brain. In the addicted brain, remarkable diminishment of the activity associated with glucose metabolism. Much the same as a normal heart versus a myocardial infarction, glucose metabolism being altered and no longer functioning in the same manner. Now, this usually does not resolve. This can with abstinence from these substances. But it does alter the decision-making in the midst of addiction, and it alters it in such a way that it contributes to the fact that the individual with addiction doesn't recognize that they have a problem and continues to go down a path supportive of the addiction itself rather than of recovery. So the satiation or stop message becomes weakened because the frontal cortex is, in most situations, giving us the information to say, why are you still doing this? I've been getting into trouble, the consequences are mounting up, but I'm not stopping. And part of the reason is because of the supraphysiologic nature of the drive itself, associated with the increased dopamine being released, but part of it is that the frontal cortex itself is no longer as capable of intervening upon the behaviors. Another way of looking at this, different type of scanning study, at least on the top, looking at dopamine D2 receptors and the glucose metabolism. So we had a control and a cocaine abuser, and they're examining how both in this part of the brain, in the limbic system, in the limbic system as well as in the orbital frontal cortex, we've got both changes in the glucose metabolism, but also in these D2 receptors. Now, when I said that we don't understand why this is a lifelong problem, we also don't understand what separates those of us who don't have addiction or don't have a predisposition to addiction. When we use alcohol, we get the same increased release of dopamine. Why doesn't that cause addiction itself? About 12% of the population that uses alcohol becomes alcoholic. And yet, in those that are predisposed, in particular genetically to addiction, and we're going to get to these vulnerabilities, a much higher rate of addiction, 3 to 6 times higher than the general population in the male children of adult male alcoholics, and very similar in the daughters of those alcoholics. And we think it's probably a dopamine receptor alteration associated with genetic function, genetic changes that results in addiction itself, but there's also the potential for no genetic predisposition with significant trauma in childhood that could alter dopamine receptor function, as well as other social activities, and I'll show you a real interesting study about that. So in addiction, basically, the message gets stuck on I want more, and that message supersedes almost all other messages to the individual. We don't see that in early addiction. We see it in late stage addiction, when an anesthesiologist addicted to fentanyl is standing in an operating room at 6 o'clock in the morning before anyone else is around and has dumped out the sharps box, sifting through dirty needles and broken vials, trying to find just a few drops of fentanyl left in a vial or a syringe to inject himself with. And an episode that actually happened at Frank and my alma mater. And that was the kind of the indication of addiction that got this resident into treatment. So if we look at a bit of a summary of these reward pathways, we've got a reprioritization of drive states, weakened recognition of the consequences, a very part of the diagnosis itself, weakened ability to inhibit the response to continued use, as well as use becoming uncontrolled by the cortical activity that should stop it. So all this brain neurobiology, whoa, that was a good one, try it, Hobbs, just poke his brain right where my finger is. So genetic vulnerability itself, I've mentioned it. When the researchers suggest that the genetic risk is between 40 and 60%. So it's the primary risk associated with addiction. And we certainly see it by culture, certainly see it in family studies. Multiple genes are involved. In the folks looking at alcoholism itself, they're saying at over a few hundred genes involved in the response to alcohol. Alcohol is a solvent. It's hard to study. And it just kind of goes all over, but there are specific receptor sites associated with our response to alcohol, and it specifically increases dopamine like any other drug. And a few genes have been identified that are protective. We know that alcohol disorders cluster in families, appears to be genes related to the alcoholism. All the types of studies examining genetic relationships have been positive. And there also are the hereditability associated with other drugs of abuse that when they've been examined, not as much work in that area, because it's one thing to find a group of alcoholics to study that haven't used cocaine and other drugs, but quite another thing to find a group of cocaine addicts that never used marijuana or alcohol. Looking at these genetic vulnerabilities, here's some of the data. I know our next talk's on genetics, so this is a slight prelude. Just a few protective polymorphisms that have been identified. Alcohol dehydrogenase enzymes for alcohol metabolism can be protective. Some cytochrome P450 enzyme protective for nicotine addiction, actually. And again, for coding to morphine seems to be protective in regard to codeine abuse itself. But genetic vulnerability also results from these changes. Gene clusters associated with nicotine dependence have been identified, as well as for alcoholism and for dopamine itself, dopamine receptor polymorphisms that I discussed earlier. What about other factors besides genetic? We've got environmental risk factors may also play a major role in addiction. Low socioeconomic class, poor parental support, some fairly vague but common problems. Drug availability. When I'm not in Utah, I'll often use, Salt Lake City as an example. If I'm walking down the streets of North Minneapolis, I might see 6 or 8 cocaine dealers, in a few block area, and here that'd be a little less likely, and there's certainly less alcohol use in the general population here compared to Wisconsin, where they have the highest per capita rate of alcohol use. And so the drug availability, as well as just cultural activities, do alter the risk for our children. All three of these consistently relate to risk of self-administration, and as a result, risk of addiction. We know that stress can be a common feature, as well as co-occurring psychiatric illness, which does increase the risk of addiction. This is a study I kind of referenced a bit earlier. This is a remarkably unusual study. It's from 2002. They're looking at these rhesus monkeys, and they were housed individually, and they examined this dopamine receptor availability in their brains, and they found no real differences among these groups of monkeys. And then they put them together in social groups of 4 in a single cage, and they immediately developed a hierarchy with a dominant monkey, a real subordinate monkey, and then kind of the second and third monkeys in between. Dopamine levels were pretty much flat prior to this socialization experiment. Once they put the monkeys together and then rescanned their brains for examine these dopamine levels, they found that the subordinate monkey didn't have a change in dopamine level. It's the same as the precondition. However, the dominant monkey had a remarkable increase in dopamine level. It's kind of a measure of dopamine level, dopamine receptors. So the belief is that dopamine receptors were upregulated, as well as dopamine function upregulated in the dominant monkey. When exposed to cocaine, the subordinate monkeys were the ones that used cocaine. The dominant monkeys had protective increases in dopamine levels, inhibiting their need for cocaine at all. And the second and third level monkeys in between, they lined right up. It was just 1, 2, 3, 4 in terms of who was going to use cocaine and how much. So there really is, when we think about stress and the potential for altering our brain function, for altering our need for substances, it's pretty well documented that this is a possibility, even if we're afraid of anthropologists. Now, this is a disease of our youth. Hasn't been described that way. It was interesting to hear the prior speaker talk about depression in our youth, but addiction itself is a disease of our youth, and it has to be considered a vulnerability because our children's brains are still developing. Myelination isn't complete until the mid-20s. And with that development, they're much more likely to be altered. Their brains are much more likely to be altered by the use of these powerful substances. If in an adult brain the use of methamphetamine results in a dramatic release of dopamine, it may alter, the neuroplasticity of that brain to be a little bit different over time. But in an adolescent who's just, still in the midst of myelination and developing these nerve pathways, it could be a dramatic change. And you can see from this slide that we have the most common age of use is between the late teens and early 20s across the lifespan. That's when we... This is illicit drugs. But it's not that unlike the curve for alcohol. And this suggests that this is, the invulnerability of our youth, the risk-taking aspects of our youth do put them in harm's way in regard to the potential for addiction. When we look at that a little bit closer, again, adolescents are vulnerable to risky behaviors of all types. Their brains aren't fully developed. The neuroplastic changes are more likely. Their experimentation increases the risk of addiction. In fact, there's good data that shows that the earlier in life that an individual experiments with alcohol in the United States, the higher the likelihood of alcoholism later in life. Education can help limit the risk of use and experimentation, but it's not the entire answer. And we look at some aspects of prevention for our youth in particular. Again, education is worthwhile, but by itself not adequate. The prior speaker had a question about marijuana, and my children, my son and one of his best friends and I were on a drive one time, and they asked me about marijuana just out of the blue. What they found remarkably interesting was discussion of the neurobiology of marijuana. I mean, you'd think that would just bore them to tears. But we actually have an endocannabinoid system, much like the endorphins and enkephalins of our internal opioid system. We have a system in our brains that's set up with a THC-like neurotransmitter, and it's involved in almost all physiologic functioning. And from that discussion went on to discuss how a basketball player might not recognize a new move put on by his friend because of downregulation of receptors in the amygdala, which would be part of the memory aspect of the brain for recognition of novel events. And when that player kind of drives by 3 or 4 times and people wonder why this guy can't play defense anymore, it's because he's been smoking pot all the time and overdriving his brain in regard to this internal cannabinoid system, and now can't respond in the same manner that he once could. These guys thought that was pretty interesting, and actually the best reason they'd ever heard for not partaking in marijuana. I don't know if it altered behavior over time. I mean, they're both in their early 20s. Who knows? But it was a fun conversation. Supportive community activities, supportive role models. We can't miss the importance of this. Teaching our children about these substances and how they're used appropriately. In Jewish culture, alcohol is not much of a problem, probably because of genetics. However, they also have really ritualized use of alcohol compared to the rest of us in our country, except for some other religious groups. Much different than a Mormon culture where it's just not acceptable to use, where it's hard to learn from that, except that one shouldn't do it at all. In a Jewish situation, the children learn that there are accepted uses of alcohol, much like Southern Europe, where although alcohol is used regularly, it's not used in the way we do in the United States, which is just to intoxication, to party. That's kind of the cultural influence we have on our children here. In Southern Europe, that's changing. They're kind of westernizing their look at the use of alcohol. However, in a general way, it's more ritualized. It's with meals, with celebrations, with limited sort of use, but ongoing use. Treatment implications associated with this. We need to identify this disorder early, and we need to help our kids understanding in regard to the use of these substances. We need to know that these are chronic illnesses. It requires long-term care, not just a single treatment episode. You can't just send someone away to a treatment center for 30 days and expect them to be absent lifelong. Even though we can't fully define exactly what this lifelong aspect of this disease is. That relapse can be temporary, a setback, not failure. Genetic subtyping and genetic markers are being established. We're hoping within the next 5 or 10 years that'll be helpful with pharmacogenetic testing to examine the pharmacologic interventions that could limit use of certain substances. Right now we have 3 medications that are FDA approved for alcohol dependence. Again, examining brain dysfunction can drive our treatment decisions in terms of length. We had a emergency room physician who came up to one of our treatment programs who'd been using methamphetamine. He was about 48 years old, hadn't had any history of alcohol or drug problems in his life, started dating a woman who was using methamphetamine. He got involved in methamphetamine and just went downhill like a toboggan. And he could not recall where his room was on the men's unit in our treatment program. There's only one hallway in this particular facility for the men, and he had to walk down that hallway and find his room, and he couldn't remember where it was. He was functioning as an ER doc up to the day of admission. And he also could write beautifully. He was a very brilliant guy, but he'd write an assignment that he'd hand in the morning, and by late afternoon had no recall of what he'd written. That, unfortunately, lasts 9 to 12 months in those that have overused methamphetamine significantly. So when we look at our treatment decisions, this guy shouldn't have been returning to the emergency room within about a year or so, and he didn't because of this, ongoing brain dysfunction. Similar things can happen with alcohol, tend to resolve quicker, although there can be more lasting damage from alcohol. There's healing communities. There's in the Native community, Native American community, they've got something called wellbriety, where they're trying to heal entire reservations rather than just the individuals that have the disorder. Now, they certainly have good motivation for that due to the high risk of addiction in their population, and it's made some remarkable gains in certain parts of the country, and is suggestive that we could do that in other communities. And back to the monkey example, that monkey research, can social acceptance improve our dopamine D2 receptor amount and availability to protect us? If monkeys have that kind of response with an increase in the dopamine D2 function, why can't humans under certain circumstances? Again, treatment implications. There's multiple brain circuits involved, and we tend to kind of look at addiction singularly, and we need to start to examine it from a much broader perspective: reward, motivation, our stress response, the learning and memory, inhibitory control, executive function, and really examine the things that can help people in shifting that significantly early in their care. Again, pharmacologic interventions are getting a lot of attention, and by necessity, we need to find things that we can do to interrupt this problem and help people move toward abstinence. There's vaccines being developed for nicotine, for cocaine, and they haven't gone beyond that at this point in time. And the nicotine vaccine makes sense to me. It isn't a very long-lasting vaccine at this point in time, and it'll have to last much longer to get to market. But the cocaine vaccine's less useful in my mind, because a good cocaine addict that in a weak moment says, "Okay, give me the vaccine," and can no longer get high from cocaine, is just going to go buy some methamphetamine. So by itself, our pharmacologic interventions will be beneficial, but not the answer. Again, enhancing the salience of our natural reinforcers as part of the treatment of people with addiction, so that they start to realize the importance of other life events again, and strengthening inhibitory control and decision making. Limiting altered conditioned responses. Once people are caught up in this in an unnatural way, to start to help them move beyond it with specific types of therapies. Stress reduction skills can be beneficial, improving of mood, anxiety, and other co-occurring illnesses. In our programs, in our residential adult programs, 75% of people that come in have a coexisting psychiatric illness prior to admission, and it's over 95% of our adolescent young adult population. So we basically do treat both. We don't have a choice. And the use of drug courts actually can be a means of requiring drug treatment and long-term monitoring. One of the advances in the addiction field that's just now kind of being recognized a little bit broader came out of the treatment of physicians and other healthcare professionals, where the long-standing monitoring of these individuals results in tremendous recovery rates compared to the rest of the population. One of the few illnesses that we can see a distinct difference between the treatment of a physician population versus the general population, where general population at our facilities, about 50-55% total abstinence for the first year, but with physicians at 5 years, we're talking 75 to 90% abstinence. So a dramatic difference, probably related to motivation on the one hand to maintain licensure and one's professional activities, but also because of the monitoring that takes place. Most of you have probably known physicians over your careers that ended up with addiction and involved with the state programs, and the requirements are pretty stringent. They have to go to long-term treatment. They usually get much better treatment because of that than the rest of the population. You average 60 to 90 days of treatment versus outpatient up to 30 days residential for the general population. They have monitoring of urine drug screens on a regular basis. They have to be monitored in the workplace. They have to be monitored by the state board in regard to all kinds of activities and psychotherapies. They don't have a choice in whether they do these things. And in the research on addiction outcomes shows that compliance with the treatment recommendations is the most telling feature of people's abstinence. Our physician and other healthcare professional population has basically required activities, or they no longer maintain their license, and it results in tremendous benefit over the long run. So we're actually looking at such programming for just about anyone. A little bit much on the science. It's time to face reality, my friends. We're not exactly rocket scientists. And I put this, a friend of Frank and I is an anesthesiologist back at Mayo, and another friend's a neurosurgeon there. And I went in the operating room with these three guys one day, just kind of following my friend Keith around as he did anesthesia, and they go from room to room while nurse anesthetists are providing most, and residents are providing most of the anesthesia. And we walk in on Mike, who's got someone's skull open, and he's in there ready to do something, and he said, and we're talking for a while, and he says, just a minute, you guys, I got to take care of something here. And, and so he could concentrate on his brain momentarily. And then Keith goes, oh, come on, Mike, it's not rocket science or anything. Now, what can we learn from 12-step programs? This is another aspect of this. Why is it? I've been describing science all along and trying to reveal that we're talking about a disease based in neurobiology in the brain, and yet the vast majority of our treatments in this country and around the world are associated with a spiritual program described by Lehman back in the 30s. And that is it's an important thing to examine from the science and see, does that make sense at all? Well, back to the discussion of dopamine, when positive emotion is just now being examined from the neurosciences for the last 10 years maybe, getting a lot more attention. And positive emotion does not get any play in the major psychiatric textbooks that we have. In fact, maybe, I don't know if there's even a sentence in any of our major textbooks. We don't talk about positive emotion, we talk about psychopathology. The psychologists ignored it as well, but they got in a little bit earlier than the psychiatrists in this new movement for the past 10 years or so. But it's clear that from the research that positive emotion and spirituality are considered dopaminergic and limbic. And that dopamine in the limbic system is essential for almost any reward. And so if it's essential for any positive reward, even though I'm discussing the salience of the dopamine associated with the neurobiology of addiction, there must be something there that's positive and helpful as well. From a report on the neurobiology of positive emotions, there was a meta-analysis. It did show that ventral striatal dopamine systems are implemented in an anticipatory positive affective state. So positive emotions are associated with dopamine release, and dopamine release has been shown to be increased in meditation, a spiritual activity. Romantic love itself, if you look at this description by one of our main researchers in romantic love, and this was in mate selection. The lover then focuses his or her attention on the beloved, aggrandizing the beloved's traits and overlooking and minimizing his or her flaws. So not recognizing the whole story, much like the addict, unable to recognize the entire story, being a bit overdriven by dopaminergic activity. fMRI studies, and we're really in the infancy of these studies, and they're often stated as factual, and even though this data is dated as factual in the literature, I think we have to, be a little bit careful in examining it, because most of this data, when they do these fMRI studies, they ignore all of the baseline activity going on in the brain and kind of focus just on the high levels activity in these certain areas, which may not be the whole story, yet it's where we are right now. And again, the ventral tegmental area, part of the limbic system, absolutely associated with romantic love. And they were able to specifically distinguish in these studies between sexual activity, which certainly is dopaminergic, and romantic love itself. The dopamine pathways, again, in the reward system of the brain, play a role in pleasurable feelings, focused attention, motivation, and goal-oriented behaviors associated with romantic love. And so we've kind of, in medicine, we don't talk a lot about love. We don't certainly count on it as a therapeutic activity. And yet, when you talk to people that start to go to 12-step meetings, talk to people that go into good treatment programs, they will talk about a sense of acceptance, a sense of spirituality, and a sense of love that really got their attention and helped them move forward. George Vaillant, who's a Harvard psychiatrist close to retirement, has one of the longest-term behavioral studies done in history. He got involved early in his career in this study that was started by a couple of psychologists there earlier, where they looked at, unfortunately, just males, but Boston area males, or a cohort study with Harvard freshmen coming into school. Over 75 years ago, this study started, and they used all of the psychological testing methods that they had at that time in history, and then followed these people over their lifetime. So you start at age 18, basically, a bunch of guys in Boston, high level of Irish Catholics, high level of alcoholism. And so they ended up with a lot of alcoholics, actually in both groups of the Boston area youth as well as the Harvard freshmen. At a point later in the study, they asked Vaillant to get involved and look at the alcoholics, and he's had the opportunity to follow these folks and even interview some of them well into their 70s and 80s and 90s. Just an incredible study. He reviewed that study as well as the addiction literature in a book, The Natural History of Alcoholism, and described these 4 factors as the most pertinent to relapse prevention, or basically prevention of ongoing addiction. He said that external supervision, ritualized dependency, new love relationships, and deepened spirituality. So it wasn't pharmacology, it wasn't neurobiology, unless you start looking, beneath this with some of the explanations I've given. So external supervision, often as therapists, we don't like to hear about external supervision. It sounds like a negative activity, like someone else is making the change for me. But addiction's based in the limbic system. Reptiles don't have one, and you can't train them, but we have one. We actually, evolutionarily, we care for our young. Reptiles don't care for their young. They eat them. We actually spend a lot of our days and years caring for our young, and do so innately. So there's some sort of activity associated with the limbic system that drives us to do that. In AA, most religions, professional athletic coaches, personal trainers, they don't rely on free will. They tell people what to do. If you're going to get back into shape to go run the marathon, you got to follow a certain routine or it's just not going to happen. External supervision guides new decision-making, new behaviors, keeps people on track, keeps a memory fresh of the reasons for the change itself. The individual doesn't have to remember the whole story. And again, back to the physician's health program, all that monitoring, all that external supervision alters behavior over time. Even though after 5 to 7 years of involvement, there is a bit of a dip in the recovery rates when they go off supervision, it still doesn't even come close to the rates in the general population. So about ritualized dependency, again, thought to be a negative thing. These alcoholics and addicts are now just addicted to something else, and the argument is that that something else can actually be positive and play a positive role in their life and help with behavioral change. Behavioral change requires great effort. A pretty famous psychotherapist was speaking about a little alteration in the kitchen of her house. She'd lived in the same house for 50 years. Her pantry was below the staircase. She opened the door, reached in, and pulled the string to turn the light on in her pantry to grab things to cook every day, basically, for most of that 50 years she was living there. And one day, she had the closet, the pantry redone a little bit, and they put in a light switch. And it took her 6 months to quit reaching in for the string. We don't change easily. And yet the expectation is that we change on a dime, that somehow within a single, few-week period, we're no longer going to do all these negative things we were doing. This ritualizing dependency can be a compelling reinforcer, something needed for folks that are just trying to address a remarkably compelling reinforcer. Alcoholics Anonymous and 12-step programs support this. They recognize that this is just fine, that people can be dependent for a while on something new, that it's not going to hurt them. And they also know that punishment doesn't change habits. As a parent, sometimes I'd forget that. And not easy to keep that in mind, but when people initiate involvement in a 12-step program, they often are welcomed by strangers, they're hugged by strangers, they have this sense of acceptance and love, and it keeps them coming back for more. It's reinforcing this sense of love from the other individuals going through the same thing. Unlike coming to someone who treats them, in a strict sort of clinical manner. They may come back because I need to, but not necessarily because I want to. Forgiveness eliminates the extreme shame and guilt of addiction. It's hard to gain that forgiveness from the family members that went through all of the difficulties with the individual, probably burnt a lot of bridges, and that forgiveness and acceptance is not really going to be there, but it can come from people that didn't have to go through that with them. New love relationships is also on the list, and he didn't mean new sexual relationships, new love relationships. In early recovery, too much anger in these old relationships to provide this for the individual. It's hard to put all that behind and now see someone who's trying to stay sober anew. They got to bond with those that hurt them in the past, and it's not easy. While with strangers, with new people, it can be much easier. It can be healing while it's limbic, it's dopaminergic, as we were discussing. Cognitive strategies are necessary, but AA understands where addiction really lies. It's subcortical, where love's of primary importance is, and a well-thought-out plan doesn't necessarily register in a time of need. So when the individual is just fraught with craving and about to walk back to a dealer to grab some cocaine, it's not necessarily the cognitive intervention that I've taught them that's going to make the difference. It might be the fact that they'd established a new relationship with a friend in that AA meeting or that CA meeting or whatever, and they think they might be letting down that other person that actually could get their attention and make the difference. And the most common aspect of recovery from alcoholism itself that's described is deepened spirituality, and that's for people that attend 12-step meetings and those that don't and get sober. AA is inspirational. There's altruistic group membership, and a belief in a power greater than the individual is emphasized so that the person is no longer just relying on themselves. So human attachment and spirituality provide substitutes for the drugs at the level of the brain dysfunction, the limbic system. So that's why we're starting to examine these positive emotions in the treatment of addiction and the activities in the limbic system, not just because AA's worked for the last 75 years or so, but because it actually fits with where addiction lies neurobiologically, and that we can learn from that and develop other therapies that could powerfully influence people based on that. It's the language of the heart that's used by AA, and I know, if we're doing our jobs right, we still have that same language of the heart for our patients that come to us as well. And it can reach past addiction to the real core of the reward center. So when I look at all of this information, what I see is an opportunity to blend the science and the spiritual. And I really see dramatic findings advancing in regard to both our understanding of the neurobiology of addiction, but also the neurobiology of love and spirituality that can drive change as well. I think we've ignored that in the sciences, and probably with good reason. And it's easy to give too much power to something like that. It's not controllable. It's not necessarily measurable. And yet there are people that are measuring and examining this in a way that I think will drive change in a lot of the neurosciences over time. Really appreciate the opportunity to talk with you today. Are there any questions along these lines?
Administration of dopamine in pill form or injection would help addiction?
There really has been examination of the dopamine agonists to see if they make a difference, and thus far we haven't found them to be very effective in the treatment of addiction. And so it has been examined, and not quite sure why it isn't, a simple matter of altering the amount of dopamine, but it appears to be primarily receptor function related, not necessarily just the amount of dopamine.
My question is, a lot of addicts on narcotics, they are clean, and then they get an injury, and they come back. And I'm reluctant to give them a narcotic because of their past history. What is your thought on that? Can you do that without jeopardizing them?
It's a real quandary for the provider, and yet I've done a lot of work with pain and addiction, and the truth is, when people need treatment of pain, whether they have an addiction or not, they do need pain treatment. The key is establishing an increased level of structure to try to limit the potential for relapse or problems in that setting. So in acute pain, straightforward, just treat them like you would anybody else in terms of amounts and doses. Don't give PRN dosing, because then you leave the decision in the brain of the person who shouldn't be making any decisions about whether to take 1 or 2 or every 4 or 6 hours. What am I going to do? And yet with chronic pain, it's a different story. Chronic pain, the jury's out about whether opioids are useful in chronic pain. The current literature does not come down on one side or another on that yet, so some people do tend to respond well to chronic opioid use, and some people get sensitized from it, develop an increased sensitivity to pain itself. So that's a more difficult question, but most opioid addicts will tell you that their tolerance is lasting. And that's people that are in good recovery, that really are very concerned about the use of opioids. But that can look just like the person who's trying to scam you for opioids, and so it really makes it tough on the primary care provider. But as a general rule, if someone in recovery has pain, try to treat them as you would anyone else. Involve other people in the situation, their spouse, friends, sponsor, people that can help them stick with the right amount of medication.
Appreciate your talk. I'm from Montana, which has become a medical marijuana state. Increasing numbers of people are using medical marijuana for whatever reason. and they're using it theoretically for chronic pain. What's the future of medical marijuana for pain? What will become of these people next year, the year after, 5 years from now, with their use of marijuana for chronic pain?
Okay. Well, there's good, scientific evidence for using marijuana to treat pain because of the way that marijuana actually works neurobiologically. It does play a role in our brain's response to pain, and it does reduce some pain. Only mild to moderate pain does it affect, though. So it's really a limited resource in the treatment of most pain. So that scientifically we've got something that tends to work. Smoking anything is hard as a physician to support. When there's good treatments of pain out there that don't involve inhalation of smoke. That could be damaging. And there is now, it's hard to find marijuana smokers that hadn't smoked cigarettes to study, to determine whether they have lung cancer separate from a nicotine-using, population. But there has been some studies that have shown that there is the potential for cancers associated with cannabis use by smoking. Now, any time a drug has been introduced into a culture that wasn't using it before in the history of illicit substances, or there's been a new way of using the substances, a la crack cocaine, suddenly you can get it to the brain faster, the rates of addiction will go up in response to that, and they'll peak and then they'll kind of level back down a little bit, but they'll level back down a little higher than they were originally. The potential for addiction to marijuana is low, maybe in about the 6% of those who use it range. So it's not highly addictive, but it is addictive, and it has that potential. I'm from Oregon, so a medical marijuana state. It's just caused all kinds of problems in the workplace, actually. And just now the Oregon Supreme Court, within the past month, decided that if you're using marijuana in the workplace, even if it was appropriately, determined by a physician that you could use it for a distinct illness, that's not acceptable, that you can be fired for that reason. That was an unusual decision in the state of Oregon, which there's a lot of marijuana there and a lot of pro-marijuana activity. My bias is that this is a fairly safe drug. I mean, if you compare it to alcohol, if I put alcohol's potential damaging physiologic effects, all medical negativity of alcohol on this screen and marijuana on this screen, the alcohol screen would be overwhelmingly worse. And yet it's legal. So I'd say the medical marijuana issue is kind of it's just a stepping stone toward, basically legalization of marijuana. They were able to get kind of a loophole to do this because the neurobiology does support it, and some of the responses on the part of certain people and certain illnesses. However, I think it'd just be simpler to legalize it, tax it, and let people use it. There's a limited addiction potential associated with it, and keep us as physicians out of that equation, because I think it puts us in a quandary, and I don't think it's an appropriate one for us to be in.
Does it continue to work for pain?
Over time, I've seen people that have used it for long periods for pain, and they say that it works, and that the study, there's no long-term studies, so I can't really reference anything that would be helpful, except, a few people that tell me that it has. I've seen people use it for bipolar. I've seen them use it for anxiety, for ADHD, for all kinds of things. I've seen snowboarders get, medical marijuana cards for sprained ankles, and not because they had a real bad sprain. They just wanted legal marijuana.
I'm going to be going home pretty shortly. I thought I'd call my wife. Is there anything I can do to get her dopamine system a little jived up? Anything I can say over the phone that would work?
You just tell her how much you really love her.
Okay. Tell me, now, let me get this straight. The dopamine system, let's say you're drinking alcohol. Is that a defense against alcohol, or does the alcohol turn on the dopamine system to make it more desirable? It
makes it more desirable, so it's not a defense. In fact, it can undermine our defenses, especially for those predisposed to alcoholism. It makes it much more desirable because the limbic system in those parts of the brain that are recognizing that response are basically saying, if in those predisposed, this is the best thing that's ever happened to me. All subconscious. It doesn't rise to the level of consciousness, but the individual in that situation knows one thing: I'm going to do that again.
Thanks.
Mm-hmm.
My question's more along the lines of children born addicted to drugs, so their parents. What is there any research or anything that we can do? Is it more of the genetic vulnerability, or if they're removed from that environment, say adopted by a family where that isn't there, are they less likely, or is the genetic vulnerability still there?
The genetic vulnerability remains independent of where one's raised. There's been twins raised apart studies that have examined that specifically. However, our environment does play a significant role. So even, I'm actually in recovery from addiction. I dropped out of high school. I went to college after I got sober. So my children are at significant risk. It turns out my father-in-law is also in recovery from alcoholism. They're probably in the 10 times, the risk level of most people. Now, so genetically they're predisposed. They're both in their mid-20s at this point in time. It doesn't look like they've developed this illness. There's still a risk that it could happen, but since they were quite young, I spent a lot of time describing to them the risk associated with their genes and that potential. And all of these genetic studies, when they have raised people apart, reveal in monozygotic versus dizygotic twins, the significant, 50% concordance rates in the monozygotic twins for addiction, even if they're raised apart. However, in most of those situations, there are retrospective studies of twins raised apart without families that had any ability to try to intervene upon that, without information that would have helped them intervene upon that disease state. So I do think if we make the effort, it absolutely is worthwhile. The prior speaker mentioned the potential for behavioral changes altering genetic function, and I think we have to believe that that's true, and it can alter the course of this illness.